judges. My paper is on chemotherapy as a first-line treatment in patients with progressive optic glioma, a series of 2 cases. No financial interest. As we know, optic pathway gliomas are low-grade astrocytic neoplasms seen in first decade of life. It can be either sporadic or associated with neurofibromatosis. Diagnosis is mainly by imaging. It is a retrospective retrospective analysis of 2 cases of progressive optic nerve glioma diagnosed between April 20 and February 21 in a tertiary care center in South India. Clinical features, imaging findings, and managing outcomes were analyzed. My first case is a 2-year-old female child with present with left eye proptosis, unsteady fixation. There was RAPD, fundus showed disc edema, adduction and elevation were restricted. VP was relatively normal. MRI confirmed the diagnosis. It was confined to the orbit. No definite chiasmal extension. So to treat or to observe, in view of relatively normal VEP and no chiasmal extension, patient was advised follow-up and oncology consultation also. So 2 months follow-up, proptosis increased, VEP also showed changes. MRI showed a suspicious chiasmal extension. So we have decided to treat, and patient was again referred to pediatric oncologist for chemotherapy. However, parents were reluctant to start the chemotherapy, and at 4 months follow-up, proptosis was considerably increased. VEP also became bad, and child was eventually started on chemotherapy with vincristine and cisplatin. 3 months after starting induction phase, the proptosis has reduced, and at 11 months after starting chemo, proptosis has considerably reduced and improvement in ocular motility was noted, but fundus left eye showed dyspallor. Last follow-up, VEP remained stable. Nerve fiber layer showed changes. So this is my second case is a 6-year-old female child with the right eye prominence since 2 years with family history of neurofibromatosis in mother. Right eye best corrected visual acuity 6/12, left eye 6/9. Right eye showed proptosis and elevation restriction, and there was bilateral retraction. Systemic examination showed multiple cafeolar spores. Fundus examination, right eye disc edema, left eye mild dyspallor. MRI confirmed bilateral glioma with extension with involvement of posterior thalamus, midbrain, central pons, and cerebellum. Nerve fiber layer also showed changes in the left eye, right eye only very few changes. So here in this case, since decrease in visual acuity in both eyes, to observe or to treat, patient was referred to oncologist because there was involvement of the brain also. But however, parents were reluctant to start. In the 1 month follow-up, left eye visual acuity deteriorated to 6/12 from 6/9, right eye remained at 6/12. With the repeated counseling, child was started on chemotherapy, and last follow-up after completing chemotherapy, the right eye proptosis reduced, visual acuity in the both eye improved to 6/9, movements also improved. Fundus examination, right eye disc edema reduced, left eye dyspallor remained. This is a serial nerve fiber layer changes. Even though right eye showed a little deterioration in the beginning, then it remained stable. Left eye also remained stable. This was the HFA done at 3 months after starting chemotherapy. To summarize, we have got 2 cases. One, gross proptosis, left eye, second case bilateral. In the right eye, the vision was grossly reduced, and the final diagnosis, finally, optic atrophy. Left eye, it remained at a stable in the second case. So coming to the discussion, management of progressive optic nerve glioma is a source of controversy because of unpredictable disease course as well as concern for treatment-related sequelae. So what is there in the history? This is a paper published in 1969 where basically rationale for the managed conservatively, but we have come long way from that. As we know, all optic nerve gliomas are not low-grade. Less than 10% can be high-grade tumors, and it can progress. The actual biological and clinical behavior of these tumors is neither fully understood nor diagnostically predictable. Various management options are available. Either we can observe or treatment like surgery in disfiguring proptosis with nil visual potential. Radiotherapy not really recommended now. So systemic chemotherapy forms the first line of treatment in progressive gliomas. It was already described from 1985 onwards. The first line chemotherapeutic agents are vincristine and carboplatin, well tolerated. 3-year and 5-year progression-free survival rate is 77 and 69% respectively. Only few side effects. Carboplatin has got some allergic reactions. In 2004, SIOP, low-grade glioma trial has come, and the overall positive response rate is 83.7%, while the complete and partial response rate is 50%. So this is we have compared many studies. The recent study by Falson et al. Published in 2018 suggests pre-existing visual damage indexed by the higher rate of poor initial visual acuity limits visual outcomes despite chemotherapy. That highlights the importance of starting chemo at the early stage of visual deterioration. Other regimens are also available. So why chemotherapy? It is relatively safe, arrests disease progression and arrests further visual deterioration. In our study, none of the patients reported any side effects. Proptosis and visual acuity improved or remained stable. First case, the advanced damage occurred prior to starting chemo, leading to poor visual outcome. No long-term follow-up available. So to conclude, needs more awareness regarding the need and safety profile of systemic chemotherapy in progressive ONGs, needs close follow-up for signs and symptoms of disease progression, and start chemotherapy at the earliest sign of progression for better functional and cosmetic outcome. Thank you.
How long was the follow-up?
1 year. After completing chemotherapy.
Well, Marian, your second case was a classical case of optic nerve glioma, but in first case there was an eccentric lesion, not the classical glioma like axial proptosis was there. It was abaxial proptosis, and lesion was also more like of optic nerve meningioma. It was not a fusiform enlargement of optic nerve, but it was an eccentric enlargement of optic nerve going supranasal. So what is your take on it? Can it be
a 2-year-old child?
No, but you can get meningioma, though they are not common, but you can get, because that is not a classical glioma presentation. You can show your CT scan once again if you are having it here, because in glioma you don't get such picture. So I think though in meningioma also, like, they are difficult to operate in this particular case, so giving chemotherapy is fine, but just for diagnostic part I think there is some doubt on it. So that's all right, otherwise it's a nice thing.
Thank you.